of healthcare, diagnosis, possibly even research, can be used for other purposes, paternity, ancestry.
We'll come on to explore those purposes now, if we may. But that is very helpful to understand that there's that if we talk about health-relevant data, that's obviously quite an expansive definition. There's no kind of fundamental disagreement about the scope, as it were. It's the uses and the consent that the questions that arise. So I want, through my colleagues, to explore some of the potential benefits of linking data sets in this way. So I'm going to start with Graham Stringer to do that.
Welcome, Professor Morris. Can you just list the specific benefits and risks of sharing and linking health data?
So the primary aim of linking and sharing health data has to be health improvement, improving people's lives. If you look at the best performing health systems in the world, they have two things. They have real-time information sharing across what I call journeys of care, primary, secondary, tertiary social care, that allows optimal management. But they also have the abstracted capability to research, to analyze healthcare quality, and to innovate on those data at scale. And that allows health systems to strip out waste, variation, and harm. So in terms of benefits, health improvement is the main focus of activity. And in my own world of diabetes, 20 years ago, locally, regionally, nationally in Scotland, we developed a real-time information system that linked primary, secondary, tertiary care to drive improvements. Within 4 years, we reduced amputation by 40%, laser treatment on the eyes for blindness by 46%. But we also, with the public, embarked on research activity, clinical trials, epidemiology, but also genetics. So you have this virtuous learning health system where we use data for care, then abstract it for multiple benefits, for research and innovation. Final comment is this is not new. The UK has been doing this for 30 or 40 years. I think it's come alive during COVID, where we've seen a real convergence of care and research. But for example, when the smoking ban came in, we recall that. Did it work? Using linked health data, we showed that it reduced admission for childhood asthma by 18% and admission for heart attacks by 19%, and 67% of that was in non-smokers. So we've got good evidence of using data. Also in clinical trials, we can use data for long-term follow-up. There was a study called WASCOPS in the west of Scotland, 5,000 Scottish men. The initial trial took 5 years, cost £38 million. They were able, using health data, to look at what happened 20 years later when they'd all gone home, and the risk was sustained, 18% reduction in mortality 20 years later. So the benefits are pluripotential in terms of health improvement, clinical trials, but also in terms of epidemiology, discovery science, and innovation at scale.
That's the plus side. But I also asked about potential negative side in terms of risks of sharing and joining this data up.
So I think a key theme for us is demonstrating trustworthiness, because we are privileged users, the research community, of data of the publics. So the risks, I think, come down to demonstrating trustworthiness in terms of privacy, confidentiality. And to be trustworthy, one needs to be honest, reliable, and competent in how data are being used. I think we'll come on to it later, but in terms of risk, we have to ensure that there are as many multiple safeguards in place to ensure that the way data are handled are in a trustworthy way. And there are We call it the 5 safes approach in terms of safe people, safe data, safe places, safe outputs, which support the trustworthy use of data.
Can I ask the same question about the benefits and risks of sharing the data with commercial entities?
Yes, I think that's, and again, if we use COVID as a reference point, what we saw with COVID from the diagnosis of a new disease in January 2020, if we look at the response in terms of diagnostics, vaccines, antivirals, it was a remarkable triumph of science, but it was also a remarkable triumph of collaboration between government, service providers, including the NHS, academia, and industry. And I would argue if we're going to be able to address the pandemics of cancer, cardiovascular disease, and mental health as we come through the pandemic, we need to define trustworthy ways of engaging with industry so that we can innovate at scale. So it's about being transparent about trustworthy partnerships with industry and being really clear around this principle of benefit sharing, so that we are transparent about who is accessing data, how and for what purposes, but importantly, what are the principles and best practice of benefit sharing is equitable. And to achieve that, I think we need to be much better at engaging the publics with constant dialogue, involvement and engagement to work through what is regarded as being trustworthy in how we engage with industry.
Ask Phil Booth the same pair of questions twice, if you could give your answers, please.
Well, thank you. I think I'll come at it because we advocate for patients, the people whose data it is, from the basic thing that we don't know what is in any particular individual's medical history. We certainly don't know how they feel about that. But what we do know is that this information is generally can be highly sensitive. There are things people are reluctant to share with their doctor or even share with members of their own family. So the risks, I suppose, and I should say I could firmly endorse what Professor Morris said about benefits, and I don't think anyone's disputing those, but the risks, therefore, can be multiple for different individuals should their information be used, misused or abused. There could be embarrassment, as I said, people don't like to reveal certain things. It could be discrimination, and there have been legal cases where people's medical status has become available to people in the workplace, and that's led to their discrimination against them. It also, unfortunately, leads to things like scams and unlawful targeting of the vulnerable. And we've had to deal with a case like that with a company called Pharmacy to You. So this is why we do advocate, as Professor Morris says, and have done for many years, for the use of these trusted research environments rather than the dissemination, the copying of this individual level linked data out to various entities. The main risk, we should say, I think we're in agreement here, is trust. We don't want to collapse trust, because without trust we don't get all the positive benefits. And this has been demonstrated by projects like care.data in 2014 and one called GPDPR, the General Practice Data for Planning and Research, just last summer, and how the public responded to that. And it's not just a theoretical. At an individual level, loss of trust in the fact that what someone tells their doctor will be kept confidential may mean that people don't share information that is critical to their own health. And as the pandemic has shown, that can also mean critical to the wider public health. And I think you asked particularly about if there are particular risks with commercial entities. I mean, of course, it's the same thing about trust. trust and trustworthiness. But it's a pretty consistent public attitude that, quite a number of people don't like profit-seeking organisations deriving, or the idea of profit-seeking organisations deriving commercial benefit from their data. Yeah. In fact, it's one of the leading reasons why people might not be comfortable with sharing their information for medical research. And unfortunately, and historically, the NHS and the pharmaceutical industry have obscured much of this sort of reuse through what are called information intermediaries, companies which service other companies, if you like, with data. And it's by exploiting carefully framed terms like it can't be exclusively commercial, which still allows a commercial organisation to service the NHS and then a whole bunch of other commercial companies, or for the promotion of health, which goes along with the promise that patients' data will not be used for marketing or insurance purposes, but this still allows a lucrative market to thrive around what's called market insights and market access. So we believe in a TRE-only world, with proper governance and full transparency. Commercial entities, anyone, should be able to come and apply in the open for access to appropriate data for stated purposes with intended value in mind and equitable sharing of that value. But everyone has to be following the same rules, and we can't have certain types of reuse, if you like, lurking in the shadows. And I think that's a necessary precondition, really, of having the grown-up, properly informed public conversation that we've wanted and Professor Morris has referred to here.
You mentioned insurance. Do you think there is a real problem or potential problem of leak of this information to insurance companies which would lead to individuals not being able to get life insurance or having to pay much higher premiums?
I think we don't have sufficient constraints around what insurance companies are able to do, necessarily. Over in the United States, there's a law that specifically forbids the use of genomic information, for example, in certain contexts. And at the moment, there's a moratorium on this, but it's not actually fixed in law that if you've had a genomic test, your employer or insurer couldn't actually have access to that. I don't think there's as many, since we actually caught an example of this happening in 2014. I don't think there's many chances of an insurance company getting your medical records from the central sort of stores that we have. They'd have to really hide their presence quite carefully to get access to that through a process that is developed over time. But again, we have found 2 British insurance companies using what's called enforced subject access requests, which is where someone who's applying for insurance is invited to tick a box to allow the insurance company to make what's called a subject access request to their doctor on their behalf. Now, this is routing around the agreed report that a GP can give to the an insurer. And again, so while I'm pretty sure insurers aren't going to be able to just go digging in the information that is collected to NHS Digital, I do think it's clear that they do want as much information as they can get, and sometimes they're willing to step up to and even over a line.
Can you tell us the name of those 2 companies?
I wouldn't like to say, because it's quite a few years ago, but I'll certainly write to the committee with their names.
Thank you. Have we got time for a final question? Or?
One more? Yep.
There are a number of, just to Professor Morris, there are a number of companies out there that offer to, if you give them a sample of your DNA, they will tell you your family history, and there are other similar companies who will claim to tell you if you're likely to get a particular disease or you're susceptible to diseases because of the structure of your DNA. Do you think, when you're talking about sharing different databases, those commercial businesses, it would be useful to use their data?
Very briefly, if you would, Professor Morris.
So these are companies like 23andMe,
yes.
for example. You'll be aware, and I'll be very brief, that 23andMe have an existing relationship with GlaxoSmithKline, for example, to use that very large data set to enable drug discovery. But that's based upon a consented data set when they have a relationship with the commercial provider. So there's no doubt that the linkage of large genomic data sets will be transformational in terms of, but again, it's doing it in a transparent and trustworthy way. And to agree with Mr. Booth, the rules need to be the same for everyone.
Thank you very much indeed, Graham. I'm going to go to Chris Clarkson and then Aaron Bell. I'm going to need to ask witnesses to be concise. Your evidence has been fascinating so far, but we've got a lot to get through today. So concise answers to what I'm sure will be concise questions, starting with Chris.
Thank you, Chair. Professor Morris, I'm going to start with you, if I may, please, because I noticed in your CV that you were the Dean of Medicine at the University of Dundee, and I'm a graduate of that university too, although unfortunately the Scrimgeour building, not Ninewells. So I'm going to ask a question about the law regarding data, specifically the uncertainties around data sharing. DCMS conducted a consultation last year where they made some suggestions about the future of data handling, including the elimination of Article 22 concerning automated decision-making and introducing a list of recognised legitimate interests to allow for data processing. Specifically, I wanted to ask you, do you think more legislation is required around data handling, or do you think this is an issue of training and guidance?
So, it's great to meet an alumnus. So, briefly, Professor of Law, University of Edinburgh, is a good friend of mine, and he says legislation is not always the answer.
Thank you.
So, and I, two other points. I think it's about caution, confusion, and inconsistency of the current legal framework, which actually is very enabling for research. So it's around the guidance and the application.
It's using the tools we have better.
Pardon?
It's using the tools we have better.
Correct.
And Phil, could I take your opinion on that as well, please?
Sure, I share that basic opinion. To be equally concise, Medical Financial thinks that lowering the bar for those who would misuse data versus those who have to maintain the high standards like research would tend to hinder the honest while empowering the dishonest. Yeah, if we're talking about trust here, everyone has to be operating to the same rules and to the same high thresholds. And I'm afraid the DCMS consultation does not actually seem to appreciate or take account of the much broader, well-established framework of governance and ethics around both health and research.
Thank you.
Thank you very much. Aaron Bell, and then back to Chris.
Thank you, Chair, and thank you both. Following on from Chris's point and your point that we should do more with what we have, we do have a very fragmented data ecosystem and an awful lot of bodies that have an interest in this. How effective do you think the present government's arrangements are in ensuring that data sharing both benefits society but protects an individual's privacy? And if you have issues, what one suggestion for change would you make to simplify the data ecosystem? I'll start with Professor Morris.
So the ecosystem is very siloed, very fragmented, lack of consistency. For example, paper in the BMJ last year, group in London wanted to look at the outcome of people with congenital heart disease, so people born with heart defects. How is their health 5, 10, 15 years down the line? 47 sets of documents, 384 pages. The process took 2.5 years to link 5 data sets. So that is an illustration of a system which is not efficient, is not productive, and is not in the public interest. So there's a need to pull together standardized approaches for governance, access, public engagement, transparency that people subscribe to. And I think guidance from the ICO is beginning to emerge, the 14th of March guidance on research provision, but we can do a lot more in enabling principles and best practice which can be adopted by, well, there are 219 trusts in the UK, 164 universities. The data ecosystem is vast. We're working in partnership to try and address that. HCR UK, under the leadership of Cassie Smith, is working with ONS, NHSX, the devolved administrations to shine a light on current practice, where are the overlaps, where can we agree on a standardized approach, just to try and reduce the complexity of the access and governance processes.
So in terms of a single suggestion, it would be about interoperability more than anything else, so that you can connect these data sets up better.
So I think simplifying and streamlining the data governance and access processes in a very transparent way, with transparency around data use. Secondly, wider adoption of the 5 safes framework. And thirdly, meaningful public involvement and engagement every step of the way.
And in terms of picking one body to drive that, you'd say the ICO are the obvious choice.
The ICO, I think, can give data controllers confidence to allow data access and data linkage for public benefit. We're institutionally agnostic and a charity, and we are convening the major stakeholders across the UK to try and get some runs on the board in this area, because it is a sclerotic system.
Thank you. Turning to Mr. Booth, similar questions. How effective are the present government's arrangements, and what suggestions for change would you make?
Thank you. Well, I think by and large, and I certainly take Professor Morris's point that it can be a very complex process for access, but in terms of the governance bodies themselves, it isn't just the data protection regime that we're talking about here. We are talking about a whole bunch of different data controllers which have essentially collected or created the data in their relationships with patients, and how that is managed. Yeah, these are not just, data sets floating around, from nowhere. They are actually created in a context and under medical ethics. So there's a duty of confidentiality, not just a data protection duty, to all of these. Now, this could be streamlined. And what we have seen, unfortunately, has been so many different interests, angling for, lobbying for, getting resourced for their particular set of uses, that we have got this, very disparate set of arrangements, a bit of, empire building. If we had, when Med Confidential set up in 2013, since then, been investing in, a relatively small number of linked together or relating, mutually accrediting, trusted research environments, NHS Digital, like one in Wales, one in Scotland, ship and sail, maybe one for the one for genomics, the one for imaging, then there would be a much simpler way for all of this data to actually be at least managed. Yeah, there will still be rules around access, but I think the most important thing that could change is that every use of data is accepted that it has to be consensual, safe and transparent, and that we have consistent mechanisms for patients to be able to express their consent or dissent, and that will affect whether their data is in the set or not, that these will be processed in 5 safes, trusted research environments or equivalent, and that patients will be told how their data has been used. Yeah? These are all entirely practical, certainly in a TRE world, and it is far easier. I'm sure you can see it would be far easier to be having proper, transparent, trustworthy governance over a number of clear entities under the various relating regulators and laws and what have you, than to have what's at the moment seems to be a bit of a sort of jostling between the silos for who gets to use what.
Obviously, you want these clear principles to flow down. Who do you think needs to take responsibility for that then, in terms of governance? Is that the ICO again?
Well, at the moment, and certainly around health, the Information Commissioner and the National Data Guardian, statutory National Data Guardian, who we advocated for, have to work in tandem. Yeah, the ICO is not competent, legally competent, not responsible for the common law duty of confidentiality. The National Data Guardian is. I think, we are, and around health research, for example, there's the Health Research Authority and the Human Tissue Authority. I'm not saying that there is a one solution for all. I'm saying we can clarify things by being very, very straight with people and saying, the data protection rules are coming from the ICO, and those are clear. Concerns around confidentiality are National Data Guardian. If you're using tissue or data derived from tissue, it's HCA. These things are not difficult. But I think people present, and it can be very confusing because there are so many front doors to things.
You mentioned NHS Digital, which obviously holds a lot of significant data repositories. The government announced in November that it will be merged with NHS England, with NHSX and Health Education England. Is that something that you would welcome to try and simplify this, or do you have any concerns about that?
No, and this is a very important point. Thank you for asking the question. What this merger does would be to bring a statutory independent body, which we think should be one of the key sources of data, and it breaks that statutory assurance by allowing NHS England to suck it in. NHS England is itself one of the large consumers of data. It's not doing it so much for what's called for research, but what's called planning purposes, which includes a whole range, a whole host of things, many of which are perfectly legitimate, but it is nonetheless, in frank terms, it is a customer. So you don't put the governance or the, if you like, what's called the statutory safe haven into one of the customers. Will NHS England, after this proposed, there's some clauses in the current health and care bill, which is just coming back from the Lords. And there are some clauses that would basically allow, by statutory instrument, NHS England to take the powers that NHS Digital has. This would be an extraordinary sort of breach in the sort of framing I've provided to allow end user to essentially direct itself to collect the data that it wants for its own, sometimes very obscure processes. And I have to say, NHS England has not covered itself in glory with regard to transparency during the pandemic around its COVID-19 data store, and also, obviously, the attempt to get people's GP histories last summer.
Thank you. Very briefly, Professor Morris, do you have similar concerns about this merger?
So I focus on functions rather than structures. So I think it's...
Good answer.
And it's... there's no doubt that the NHS England needs to have a very high-quality, trustworthy data capability.
And governance structures.
And governance structures which are completely transparent.
Right, thank you.
Thank you very much indeed. I'm going to turn back to Chris and then Deanna. We are going to need to return to concision, I'm afraid.
Right, I will try and be as concise as possible. So transparency... It's hard for a lawyer. You're charging by the word. Transparency in data regulation, in particular GDPR, relies on people understanding how their data is being processed. So in particular, Phil, I'd like to ask you, to what extent do you think current regulation of AI in data processing is fit for purpose? And if you perceive there to be gaps, what are they and how could they be remedied?
Well, I'm afraid if we measure the culture and practices of CDEI and the opacity of DHST's AI lab, it's not fit for purpose. We have a bunch of issues with AI, really some quite wicked problems around bias, because the data that we are looking at that's being used to train these models is full of historical discrimination. So there's a clear need for not just data protection regulations, but actually looking at the accreditation and validation of these models themselves. But we would propose, Medical Ethics would propose that we tackle this and help the regulators by having what we call analysis and input reports, if you like, a certificate that shows exactly what data set has trained what model, so that anyone, but certainly public sector bodies, can know when they purchase or commission AI or machine learning services or products, they can know, what the, if you like, data supply chain has been. The equivalent of, if you like, we don't want, in retail, this product has not been tested on animals. This certificate and this supply chain thing, which would help the regulators, would be showing that no law has been broken and no data subject has been harmed in the making of this AI. We need to get more practical. There's lots of talks about ethics and governance and a whole bunch of high-level stuff. What is being done here is processing data. We can know where that data came from and whether it has been incorporated into a service or product or not. And as our ability to be able to clinically validate some of these machine learning things for live clinical use, then that needs to be added to the certificate as well.
Do you perceive there to be any problem around the black box issue? Because obviously you are talking about putting in ethical data sets, getting the certain set of results out, but obviously we don't always know how the algorithm arrives at the conclusions it does.
Absolutely, and this is, as I say, this is one of the wicked problems. I mean, we keep up as much as we can with, the research in these areas, but I don't see there being a simple, singular solution here, and therefore we've said, as we often do, let's go with transparency all the way through the process, and if there is a black box at some point in the process, then we focus all of, the appropriate sort of scrutiny and requirements on that, the outputs, if you like, that they are properly tested. You may have a black box, but we are used to, using relatively unknown things through the clinical trial process. One could still say this is a black box, like this is a pill, but there's a process that you can go through to still say, but it's okay, this actually is safe. But if we don't capture that and we just say people can start selling black boxes to public authorities, we've got a real problem. So we would say, let's get this certification bit going. We know we can look at the source of data. So if you're using a particularly badly biased data set, then obviously we shouldn't be buying that for general use. And all these other things can be daisy-chained around. It's a practical, pragmatic way of approaching what is obviously going to be used more and more in the future.
Thank you, Phil. And very quickly, Professor Morris, is there anything you'd like to add to that? I know you tend to deal with process rather than structure, but...
We need innovative regulation around AI. It's a challenge because it's hypothesis generating rather than hypothesis testing. It needs very, very large, comprehensive, annotated, detailed data sets. So it's detail as scale, and you also need very large scale compute. So we need innovation in the regulation in a transparent way. So subscribe to what Phil was saying.
Thank you very much.
Thank you very much indeed, Chris. Dana Davis and then Rebecca Long-Bailey.
Thank you, Chair. Professor Morris, I'll come to you first because I want to talk about what mechanisms are in place to actually protect privacy in data. Clearly there's already some level of anonymisation often or pseudonymisation otherwise, but how do we strike the right balance between protecting people's privacy whilst also making sure that the data is actually still useful for research and it hasn't been blurred out too much?
That's a good question. So I'll try to be brief. If data are anonymous, one loses the ability to link and the research, innovation and public benefit, utility. So there are trade-offs here, and every step of the way being honest and communicating with the publics, seeking their advice. There is an emergent model of multiple concurrent safeguards, and it's emerged from the ONS and work and the UK Stats Authority, this so-called 5 safes framework. So how do you authorise and authenticate and accredit people who are going to research on the data? How can you de-identify and pseudo-anonymise the data? How do you take the analysis to the data rather than have a data dissemination? As soon as you send data out the door, there's risk. Mm-hmm. How do you ensure that statistical disclosure control means that any outputs are anonymous? And how do you do this in a safe place which is completely auditable? And what we're seeing is, I call it power stations on a grid, these multi-tenant, secure, cloud-based, trusted research environments where project-specific workspaces are auditable, so we know what's happening. And then be honest with the publics to say, these are the benefits, these are the risks, and these are the safeguards that we're putting in place to try and minimise those risks as much as possible.
Do you feel the right balance is being struck there at the moment?
I think there are examples of best practice in the UK, and that the UK is being seen internationally as a place that is trying to strike this balance between trustworthiness, public engagement, and policies, technology, and governance, which demonstrates trustworthiness. So, but there's still more to do.
Okay. And Mr. Booth, I know you've given some evidence previously on this point around anonymity and whether true anonymity can kind of really be achieved. Can you just sort of expand on that for us here at committee today?
And I would agree with Professor Morris. Data that is useful for research, other than just pure statistical research, because statistics are anonymous, is the utility's gone. We must be clear, we are talking about pseudonymized or maybe de-identified data. That is personal data in law, and it's just it may be inconvenient, but the simple answer about this is richly detailed, linked data at individual level cannot be made anonymous. And while I heartily endorse, and in fact we've been advocating for all of the safeguards that Professor Morris has just described, he missed probably one of the most important ones out, which is giving people a choice. Given that what you are going to be processing is personal data, we should just acknowledge this. We should do all of the sensible, safe things to demonstrate that we are trustworthy to be handling people's data, but nonetheless, we cannot assume that because we're doing that, we are good people and should then be let to do whatever we want. We still need to give people a choice about what is being done with their medical records. Now, there are choices. There are what are called opt-outs, as well as obviously explicit consent for example, joining a clinical trial. But those opt-outs are still not being properly respected across the entire system, and even by those that do recognise, for example, the national data opt-out is not being applied to all data releases. So this is a point I think is critical. You can do all of those things that we are talking about, trusted research environments, 5 safes, taking the open safety model, going to the data and doing the analysis there. But you can't just do it because, hey, we've done this, so it's okay. You're processing people's personal data, and while it's not always practical to ask their prior informed consent, if people are given a general option to dissent and say, I don't want my data used for these purposes, that must be respected by everyone with certain very clearly defined legal statutory exceptions.
Well, you've spoken about the importance of kind of public trust in buying into kind of use of data. Do you think with regards to those either opt-ins or opt-outs, there is kind of enough transparency and enough emphasis put on those? Because often, you know, we see them, it's a sort of tick box that people tick through just to get to the next stage in a process. Do you think we need to go further there?
Yes, I think we absolutely do. And you know, we are talking here about a health data ecosystem, health-related data ecosystem. We have a national health service which provides the healthcare of the vast majority of people in this country, and many opportunities to interact with people. Yeah? What the government has consistently refused to do is actually just write to every patient and to be honest about what the intention is. We said this was a simple, obvious thing to do. They stuffed it up in 2014, they stuffed it up last year, and have done other ways. Once we have all of these trusted research environments that we have been promised in place, and once the rules have been fixed, and once the national data opt-out is actually made to work properly in all contexts, then it would be a relatively straightforward matter to actually communicate to everyone wants to explain what the situation now is. They've heard enough bad stories, a drip of bad sort of reports in the press, and then the occasional sort of outbreaks of attempts to get their data. Let's fix the situation, get both the sort of dissent processes and other things in place. And if anyone then does make any new initiative, it is on them to communicate that clearly, but on the basic understanding of, look, this is your rights. You actually have a right to limit who sees your data, even in a direct care context, which many people aren't aware of. That's around something like what's called the summary care record, and should apply to what are called the shared care record for direct care that is coming. But we also have a right, to opt out from secondary uses, what are termed research and planning. And unless we actually make this promise true, we're going to keep on losing trust.
Thanks.
Thank you. Thank you very much, Dana. Thank you, Professor Booth. And finally, now to Rebecca Long-Bailey.
Thank you. Remaining on the issue of ethics, how do ethical considerations differ between the sharing and use of health data compared to other types of personal data? Starting firstly with Professor Morris.
So I'll be very brief. Health data is particularly sensitive, and it is special category personal data.
Thank you. Mr. Booth.
Well, health data was created under medical ethics. 2,500 years since first do no harm. So while Professor Morris is correct, it is special category personal data. It is also confidential, and it exists within a professional, ethical environment, which includes, by the way, the academic research ethics environment for research. So I think, there are very different ethical concerns, but they are managed by some really well-established, ethical governance frameworks, and governments or new upstarts like data trust initiatives or whatever coming in saying they can fix things is throwing a whole bunch of history and good practice out of the window.
Thank you, Mr. Booth. You mentioned that special category of confidential information that health data comes under. To what extent do you think that the UK's health data ethics system, or lack of thereof, is fit for purpose at the moment?
Well, I think it could be much fitter. I'm going to go back to my point about consent. This is an important point. It may seem nitpicky and practical, but we have to ask people, because their data is confidential, and if we don't respect that confidence, we have shattered trust. So while it might be easy for an adult now to do a national data opt-out online, it actually turns out to be not easy to do it for their kids. Families have to go through a whole paper-based process, which we found out last summer. The NHS dashboards, lovely and transparent, but they show that 50% of adults who opted out did not opt out their kids. There's a problem here. The fact that, again, very transparently, published each month, NHS Digital shows that 2/3 of the data releases aren't respecting the national data opt-out. I think it's not fit for purpose, and frankly, it undermines the UK's entire data ethics if we do not and will not once and for all fix these very practical things around things like patient consent and dissent.
Thank you. And Professor Morris, to what extent do you think that the UK's health data ethics system is fit for purpose, and what changes would you like to see?
So the Caldecott principles are well established, including the 8th principle of transparency. So I think increased transparency. Secondly, the opt-out process vary across the 4 nations, so we have inconsistency. So I think that's an issue. And lastly, for some types of research, consent is intransitive. It's Honora O'Neill who writes very well. It's very valuable because it supports individual autonomy. For some uses of data, consent is a blunt instrument, and combined with authorization, anonymization, and safeguards, it's a public dialogue around the benefits and then the safeguards and the risks. So I think the role of consent in this is a key issue, as Mr. Booth was saying.
Thank you. And finally, on the issue of the opt-out system, Mr. Booth, you've said a few times this morning that it isn't being enforced, and that even when people are opting out, their information is being abused to some extent in many cases. What should the opt-out system look like if it's to be properly robust? And does the government need to create more legal teeth by the way of financial penalties, for example, for those who are procuring or sharing data that has been opted out? Starting firstly with Mr. Booth.
Mm-hmm. Yes, so the implementation of the national data opt-out across all NHS bodies has been delayed by the pandemic. The date for people to respect it has been pushed back and pushed back and pushed back. And that is, I guess, understandable. But it doesn't mean that it can be put on indefinitely. And what should happen is that it should be applied in the way that people understand it, which is, I don't want my data used for planning and research or secondary uses, and that should be what happens. Instead of, behind, if you like, behind the curtain, there are a whole bunch of, plausible legal exemptions that are found in order to continue to process the data. It just doesn't, it's not trustworthy. It just doesn't come across as honest. What we believe should happen is, and because we've got so much reorganisation going on, potentially, we're moving from CCGs to ICSs, we've got all these other things going on out of the Health and Care Bill, we need clarity. There should be a single opt-out, and I take Professor Morris's point about it will be different in Scotland, certainly, but a single opt-out that people can deploy if they do not wish their data shared even for the direct care. It's a very extreme case, but it is one that does apply to some people and needs to be there for, obviously, domestic abuse safety, all sorts of things, all sorts of reasons. And there should be a singular one that operates, not as the national data opt-out operates right now, but more in the way that what's called the current Type 1 opt-out operates at your GP practice, which is, you say you don't want your data leaving a GP practice for purposes other than your direct care, your data doesn't leave. They don't process it in some way and say it's anonymized, so it's okay, or they don't have a bunch of exemptions. You just say it just doesn't leave, and that way we can maintain trust. And I think over time, if that is in place, we would end up with a relatively small percentage of people using that opt-out. If you keep on coming back saying it's okay, fine, we fixed it now, we've done a bunch of other stuff, and you can trust us, we'll just get another doubling of the people who opted out, as we saw last summer.
Thank you. And Professor Morris.
So currently there are 3.5 million Type 2 opt-outs, which is, opt-out is a very important principle, but it also has disbenefits, because we know that opt-outs patterns are very lumpy, they're not evenly spread, and it varies 20-fold. And that could have public health.
Explain what you mean by lumpy, please, Mr.
Oh, sorry, it's not a very scientific word. So it's not even, so opt-out is not evenly spread across England. It's driven by age, gender, geography, GP practice. So it's a 20-fold variation in parts.
Your concern is that biases the sample?
It biases the sample. So, for example, if we had high opt-out in, when we're looking at public health issues, for example, Camelford, Salisbury, Sellafield, and there was differential opt-out, we wouldn't be able to understand the underlying etiology of those events. So,
thank you. Thank you very much indeed, Rebecca. And can I thank both of our witnesses, Professor Morris and Mr. Booth, for a fascinating series of answers to our initial questions. We're very grateful. I'm going now to turn to our next panel of witnesses, both of whom are appearing virtually, and I can see them in front of me, and they are Professor Christopher Holmes. Professor Holmes is the Programme Director for Health and Medical Sciences at the Alan Turing Institute, which is the UK's National Institute for Data Science and Artificial Intelligence, and Dr. Melissa Lewis-Brown, who is the Head of Research Data Strategy at Cancer Research UK. Thank you very much indeed, both of you, for joining us. Perhaps I can start with Dr. Lewis-Brown and to ask you to set out briefly what are the advantages of sharing data sets, particularly from an organisation charged with finding cures for various types of cancer?
Yeah, thank you. So first, perhaps I'll just give some context that I'm speaking from a number of perspectives in my capacity as a Cancer Research UK representative. So we're a major funder of health research. We fund hundreds of millions of pounds of cancer research each year, which includes data-enabled research, such as the data that we're talking about today. We're also patient advocates. We have an 1,800 strong network of those people affected by cancer, 5 patient panels. With whom we deep dive into issues such as those that we're discussing today. And also we're a user of health data, so we have a cancer intelligence team that analyses the sorts of data that we're talking